Highland Hospital. Highlanders have roamed these long, dusty halls for decades. They're a quick-walking, smooth-talking, rough-and-tumble bunch, known throughout the land as the fastest intubators west of the Mississippi. But there's a new pandemic in town, COVID-19, and the times they are a-changing. These days, those same cowboy heroics that earned you your reputation are likely enough to get you killed. Or at least stuck at home for a couple weeks nursing a pretty nasty URI. Running into a code room all willy-nilly without the proper personal protective equipment, like we did in the good old days, well, that plan has about as much sense as a scrambled turnip. Delayed sequence intubation, you ask? Well, that would be dumber than a bag of hammers. These days, you'd have to be about as sharp as a bowling ball to use apneic oxygenation. Oh, and your trusty direct laryngoscope? Well, that's about as useful as a trapdoor in a canoe. We have to adapt to this pandemic. We must become COVID wranglers.
It's really important to prepare for COVID Airway. So at the beginning of your shift, make sure you gather your team members, do a huddle, decide who's going to do what, and then get your checklist, your COVID checklist, to make sure that everything that you need is there.
Using the checklist, you'll designate a code room, make sure the medcode and RSI kit is stocked, PAPRs are charged and ready to use, locate and test your video laryngoscopes, familiarize yourself with the pre-assembled Airway bundle, set up your rescue devices, and finally, establish a space for safe doffing.
Now let's pick your video scope.
Equipment for each can be found in the Airway cart between rooms 7 and 8. The McGrath is a handheld video scope with a standard geometry curved blade. The glide scope has options for both standard geometry curved blades and hyperangulated blades. Make sure to use a cover while using the glide scope in order to make decontamination easier. The King Vision is less familiar to most of us, and so we'll go through a brief tutorial.
The King Vision has two parts. There's the screen and the handle. Put the two together like so, and then turn on with the on switch in the back. You should see your video display. The reason that this is different from most of our devices that we used to intubate with is that it has this channel on the side through which you feed your ET tube. So no stylet in the ET tube, and you preload it into your device, into the King Vision. The key is not to load it too far because you'll obstruct your light and you'll obstruct your camera. So just about there is good. You can hold both with your left hand. And then you can come to intubate your patient. So just like any video intubation, you want your suboptimal view, and then you feed your tube through the channel, through the cords. Once you've passed through the cords, to release the tube from the King Vision's channel, you hold the tube securely with your right hand, and then you're going to rotate the King Vision away from the tube to the patient's, to your and the patient's left to release the tube. Inflate your cuff, and that's it.
Now that we've chosen our video scope, let's make sure that we have the rest of the necessary equipment that we need to make it into the room, including the viral filter and the end-tidal CO2 monitor.
You'll also need to make sure that an Airway bundle and a medcode kit are available.
Now let's don our PPE and get in the room.
Once in the room, communication will be challenging. You will have to use an array of techniques, including writing on the glass door and using two-way radios or the speaker function on your phone. Next, you'll get set up to intubate.
All right, so you need to have your ventilator set up in order to be connected to the patient immediately after you pass the tube through the cords. So there's a few things you need to connect to your ventilator tubing. So starting over here on my right hand, your left is kind of more proximal, closer to the patient, and then down here, closer to the ET tube is more distal, if that makes sense. So first thing you want to connect is your end-tidal CO2. So this is your waveform capnometry that you have here. If you don't have this available for whatever reason, you can use an easy cap here, but it's not preferred. So first thing that you connect to the tubing is the waveform, followed by your viral filter here. The only thing that is appropriate to go between the ET tube and the viral filter is the inline suctioning, and that's because this needs to be able, the suction catheter needs to be able to go into the ET tube unobstructed by a filter or anything else. And then finally, once you intubated, you would connect the ET tube like so.
As you continue to set up, you'll start thinking about pre-oxygenation strategies.
Pre-oxygenation is key for your patient. The recommended device for us here at Highland is just going to be a non-rebreather face mask. This can deliver the most flow to the patient and is the safest from an aerosolization perspective. You just want to make sure that the mask is on the patient before you start flow to minimize aerosolization. So you have to move quickly because right now the patient's getting no flow, but connect it, it's on the patient. And then I would even take the additional measure of putting a surgical face mask over the patient and then starting your flow up to 15 liters per minute for the pre-oxygenation period. Same thing once you're ready to take your mask off. So in your intubation, when you remove the mask, you have to make sure you stop your flow first, then remove your masks.
In the obtunded patient, or in the case of a failed intubation, the iGel can be used as a rescue device.
If you're not familiar with the iGel, I recommend that you watch the instructional videos online from the manufacturer. The basic premise, though, is that you can take the iGel, give the patient a jaw thrust, like so, and insert so that it sits just outside of the airway, and then ventilate and oxygenate using a BVM with your end-tidal CO2 waveform capnography TP setup, as well as, most importantly, your viral filter.
Though not preferred, as a last resort, a bag valve mask can be used with a two-person technique. You'll have your BVM set up here with, most importantly, a viral filter. Ideally, you'll also have an inline end-tidal CO2 capnographer. As you're bagging the patient, you'll use a two-person technique. The first person is going to focus solely on achieving a good seal. They're going to use two hands with a vice grip. The person doing the bagging will give slow, even breaths and maintain good communication with the person holding the seal. Inline end-tidal waveform capnography can be used to monitor for a good seal, as demonstrated by a square waveform.
All right, so when it comes to the actual intubation, your setup is going to be pretty much the same as your usual intubation setup. You want to make sure you have your primary laryngoscopy device with some kind of backup. So here we have our King Vision as our primary, followed by DL as our backup that we hopefully won't need, and then a bougie as further backup. Beyond that, we want to make sure that we have our previously established ventilator tubing set up with our viral filter, inline suctioning, and end-tidal capnography. BVM ready to go, just in case, as well as a tube securing device. You also want to have your patient positioned appropriately, being pre-oxygenated, your suction as usual. The main differences in terms of your setup, the two things that you want to make sure that you have, the first is an iGel. This is just going to be your rescue device in the event of a failed intubation. So you have that ready, lubricated, and prepared. And then the other thing that you may or may not choose to use is one of these barrier devices, like so. In terms of the intubation itself, the key points are that though you have your suction and your BVM ready, you hopefully will not use either. The other thing is that we will be trying to avoid apneic oxygenation due to concerns for aerosolization as well. You want to make sure that you turn off your oxygen flow before you disconnect your pre-oxygenation setup. And then you want to use your video laryngoscope to intubate the patient.
Remember that chest x-ray will be delayed following intubation. Therefore, you should utilize direct visualization, end-tidal CO2 monitoring, and ultrasound to confirm tube placement.
So ideally, once you've intubated the patient and connected the ET tube to the ventilator, that circuit should never be broken. However, if the circuit does need to be broken, we recommend clamping the tube to avoid aerosolization. The first and most important thing is anytime you're going to break the circuit, the first step to be taken should be actually to disconnect the inspiratory limb, which is typically your blue limb, from the ventilator itself. This will prevent the ventilator from giving a breath while you're disconnecting the circuit and causing aerosolization. So disconnect the inspiratory limb first. If the circuit needs to be broken distally to the viral filter, tube clamping is not required, as all the expiratory secretions are still going through the filter. However, if you do need to break the circuit between the ET tube and the viral filter, clamping is recommended. To do this, we recommend putting a little bit of cloth tape just to protect the structural integrity of your tube. You can then use clamps to clamp your tube like so. At this point, it's safe to disconnect the viral filter. In this case, we're going to attach our inline suctioning. Once the tube is connected and the circuit is reestablished, you can unclamp, and you might need to manipulate your ET tube just a little bit to get it to reform to a cylindrical shape.
Last but not least, you'll greet your previously designated doffing coach outside the room and safely remove all of your PPE.
Well, this COVID sure is a doozy, but I'd bet anything from here to Timbuktu that if anyone can rope it, it's you Highlanders. Y'all are now ready to be COVID Wranglers.